right. Welcome everybody to another edition of the Cameroon Town Hall for Healthcare Providers, your town hall. It's always a pleasure to get to see you all here every fortnight. I hope you're doing well. I hope your families, home and abroad, are all doing well. Today, we're going to be talking about a very exciting topic. I can't wait to dive in, and we've got amazing speakers that will be joining us this morning or afternoon, depending on where you are. But first, before we dive in, I want to introduce to you my co-moderators for today. We have Brian, who is here with us today. Hi, Brian. You want to say hello to our viewers?
Having some technical difficulties, sorry.
Oh,
hi,
okay.
Hi everyone, and welcome. It's really great to see you again, everyone, and really thrilled for this really important discussion on diabetes, particularly the conversation around non-communicable diseases in Africa in general has really been something that's really been super exciting to me. I'm so thrilled to have really phenomenal speakers today, Dr. Kate, whom I've gone for very, very long, and I'm also very thrilled to meet Mr. Ferdinand as well. So really thrilled for this discussion today. Thanks a lot, Alison. It's good to see you.
Same here, Brian. Always a pleasure. Hi, Christelle. Are you with us?
Hi, Alison. Hi, everyone, and welcome to this new edition of the Cameroon Town Hall. The pleasure is mine to be there today to discuss about this interesting topic. Hope we have an interesting discussion. Thanks.
Thank you, Christelle. Et bonjour à nos téléspectateurs francophones. Pour ceux qui préfèrent s'exprimer en français, on a Christelle qui est avec nous aujourd'hui, qui va nous aider avec des traductions. Bon, you know, don't feel like you've been excluded just because you prefer to listen to a French presentation. And we have Louisa with us as well. Hi, Louisa.
Hi, Alison. Good afternoon, good evening, everyone. It's always a pleasure coming back to the town hall, and today we're touching something really close to my heart, which is diabetes. And I'm so happy to have like the very best of the best coming to discuss this topic with us. We look forward to having this conversation. Thank you.
Thank you, Louisa. Elvis unfortunately couldn't join us today because of competing priorities, but he extends his regards to everyone on the town hall and all our viewers online. As you've already heard by now, our topic for today is going to be touching on diabetes and precisely looking at diabetes care in Cameroon. We have two amazing, like I said, speakers with us today, and I can't wait for us to start getting an idea of who they are. But before I hand over to our moderators to introduce our speakers for today, I'm going to hand the floor to our chairman of the town hall, Dr. Muno, former Kene, to greet everyone and, you know, begin the town hall session for today.
Well, Alison, I just want to thank you guys for the commitment. All those who are moderating this, you guys have been wonderful, and everyone who is participating. And just to remind all the participants that this town hall for health professionals belongs to you. And we are here, our goal is really to change healthcare in Cameroon. One day at a time, talk about topics, get to enlighten ourselves what is happening at home, bring the diaspora close to those who are practicing at home, learn from those who are at home, and also for those who are at home to learn from the diaspora. And we also want to encourage different projects that could be generated from the town hall, or the town hall can actually help in these projects. And we have had a lot of projects that were born out of this. So once again, thank you to everyone who is here. And I want to say a big shout out and thank you to the moderators who are always here. You guys make this really, every Saturday that I don't have a town hall, I feel depressed. So I'm happy coming here all the time and getting to discuss important topics. So once again, thank you all.
Thank you, Dr. Conner. Okay, so just a brief announcement regarding the time for the town hall. As a result of daylight savings that happens in the US, the time for the town hall might have shifted for those of our viewers and participants who are based either in Europe or in Africa. So traditionally, the town hall would hold at 6 p.m. Cameroon time, which is 1 p.m. Central time. But due to daylight savings, it remains 1 p.m. Central time in the US. However, it's going to be at 7 p.m. Cameroon time. So we've had participants who joined us at 6 p.m. instead of 7 p.m. Please, you're more than welcome to join us and chat with us just before the town hall. But you could also just grab dinner and then join us at 7 p.m. if it works better for you. That said, I'm going to now hand over to my co-moderators to introduce our speakers for today. Dr. Tegomu, please, can you introduce Mr. Ferdinand? Thank you.
Thanks a lot, Alison. I'm really super thrilled to introduce Ferdinand Sonyu. Such an honor, such a really great honor to have him among us today. Ferdinand was he's the president and CEO of the Reconciliation Development Association. He initially started his career as a finance clerk with the CBC in the Cameroon Baptist Convention, where he eventually became a grant writer, administrative assistant, and eventually pioneer program manager for non-communicable diseases for the CBC non-communicable disease prevention and control program. He has wears so many hats. He's the Secretary General of the Cameroon Civil Society for Non-Communicable Disease Alliance. He's also the chair and secretary of the Africa Non-Communicable Disease Network. As I mentioned, he's the president and CEO of the Reconciliation Development Association, what's known as the RADA, and also an ambassador for the One Young World ambassador as well. He was the former program manager for NCD, as I said, and has been focusing his research on community development by inspiring broader action through his work and impact on non-communicable diseases. So it's really a great honor and really a great privilege to have Ferdinand among us today. I'm really so honored. I really have a great admiration for his work across the years and all what he's done to Cameroon. It was such an honor to have him really accept to be a part of the town hall, to share some of his experiences on non-communicable diseases, what we are doing in Cameroon and what we can do for the future. So I'm really want to reiterate how truly honored we are to have Ferdinand among us today. So thank you so much, Ferdinand, and welcome to the town hall.
Thank you, Brian. And for those of you who would want to know more about Ferdinand's organization, the acronym is RADA, and it stands for Reconciliation and Development Association. Louisa has shared the link in the chat. Feel free to take a look at the amazing work RADA is doing. I'm now going to hand over to Christelle to introduce Dr. J.C. Kate, who is no stranger here to the town hall.
Merci Alison pour cette introduction. J'ai l'honneur de présenter l'un des participants très réguliers de la plateforme, Dr. Jean-Claude Katé. Il est médecin de santé publique au Cameroun et il est aussi membre de l'Académie internationale des jeunes médecins. Aussi, en plus, il est membre de la Société internationale contre de l'insuline et membre de l'Académie internationale des sciences. Il a pour principal intérêt la lutte contre le diabète et les maladies non transmissibles, notamment la prévention et le contrôle des maladies. Et en plus, il est très impliqué dans l'organisation de la prise en charge du diabète et de toutes les pathologies et complications dans les pays pauvres et en voie de développement. De plus en plus, il est très impliqué aussi dans la prise en charge du diabète de type 1 dans les pays en développement. Merci beaucoup, Dr. Katé, d'être là parmi nous aujourd'hui et merci de trouver du temps pour cette plateforme et nous espérons apprendre beaucoup de toute votre expérience que vous aurez à partager avec nous. Merci encore.
Merci beaucoup, Christelle. And maybe for those of us who would want to reach out to Dr. Jean-Claude Katé, we have shared his social media handles, precisely his LinkedIn handle in the chat. so you can get to see a little more about him and the work he's doing. And please feel free to reach out should you have any questions or suggestions for him looking at partnerships, or maybe you just want to get the sense of how his career has been, or to know a little bit more about his work. That said, I'm going to hand over to our presenters today to take it away from here. Dr. Kate?
Thank you so much, Alison. Always nice to be on the platform, and really hello to you, Brian, of course, and Christelle, bonsoir. Et à Monsieur le Chairman qui est toujours là, qui a en fait commencé cette initiative il y a de cela plus d'un an. Donc, so I'm just going to share my screen. Where am I? All right, Alison, please, can you confirm if you can see the screen?
Yes, Kate, you can.
Yes, so today, I think I'm going to start right away. We will be talking about diabetes care in Cameroon, and I can see from the audience that I know there are many people, when I look at the names, who are much aware of diabetes, maybe internationally, and diabetes in Cameroon specifically. And really, this is not going to be really an exhaustive presentation, but because diabetes is so broad, but I would just really try to focus on some specific issues, and also really try to tell my story as with regards to my involvement with diabetes in Cameroon, of course. So really, this presentation is going to go on in three main sections. So general knowledge around diabetes, and then a focus on diabetes in Cameroon, and then really a case study, which is just really about my story. And so we all know that diabetes today, it's a global emergency. It's a pandemic. It touches every part of the world, and every population of the world, even minority populations that are found really in the North Pole of the earth, where it was thought that diabetes would be low. And so back in 2017, the International Diabetes Federation came up with these numbers. And I'm just really going to focus on Africa. And it was actually said that at that time, Africa had about 16 million people who had diabetes, and that by the year 2045, if nothing is done, the projections were Africa is going to have about 41 million people with diabetes. And so this is really represents about a 156% increase in the numbers of people who have diabetes. And this picture also shows that diabetes is actually increasing everywhere in the world. And so, about 4 in 5 adults with diabetes live in low and middle income countries, and that about $966 billion is spent on diabetes. And this has been so over the last 15 years. And so if you look at the numbers, it actually shows that from the year 2000 to the year 2017, there's been a constant, or we can say an exponential rise in the numbers of diabetes. And diabetes actually touches every age group, right from the 20s to the 80s. And this picture actually is from the International Diabetes Atlas, and with the different projections as well. But apart from that, one peculiarity about diabetes is that the prevalence seems to be higher in urban areas than in rural areas. And this is so across all the regions of the world. And specifically, if you look at these diagrams, on the left, we have numbers in Africa, and on the right, I've just put numbers in Europe. You actually see that with regards to the prevalence of diabetes adjusted for age and sex, if you look at this, as I said, it touches every age group, but if you look at around the 40 to 49 age group, you have about 5% in Africa. And if you look if you look at the European region, it's almost similar. The prevalence around 5% in this age group, but of course you have many more people who are older in the European region, so something about 20%. But one of the most hideous thing about diabetes in Africa is that with regards to mortality, you actually see that young people in Africa are actually the ones paying the biggest burden for diabetes in Africa, between 30 to 49 years, compared to what you see in Europe. So people who are actually dying of diabetes in Europe are actually those that are way older than 65 years. And so some of the key points you can see that it's that diabetes, yes, it's a global public health challenge. It affects people from every age, from young to old. The burden seems to be very huge in Africa, with the young people who are actually the economic powerhouse of Africa fall into the burden of the disease. And also, one thing I didn't mention is that our health structures in Africa, they seem not to be suited for chronic disease care, because we have been so infectious disease focused over the last century or so. And so really, what is diabetes? And the answer is diabetes is actually a chronic metabolic disease, which is characterized by raised blood glucose. And of course, we call this hyperglycemia, but as a result of poor insulin production, action of both. And of course, diabetes, because of the high or raised blood glucose levels in the body, it's going to cause serious long-term complications. And generally, as a misnomer or not, when we refer to diabetes, we are actually most of the time talking about type 2 diabetes, but there are actually 2 or 3 main groups or 3 main types of diabetes, which are type 1, type 2, and gestational diabetes, which is first occurrence of hyperglycemia during pregnancy. But there are other specific types of diabetes. As, for example, someone can develop diabetes after maybe a pancreatic cancer or surgery that touched the pancreas, or maybe due to other endocrine pathologies such as Cushing's disease and other metabolic diseases. And you also have genetic causes of diabetes. So all of that really fall within the group of other specific types of diabetes. And just really to mention that how is diabetes diagnosed? It's important to note that there are 4 main ways by which we can diagnose diabetes, either by doing a fasting plasma glucose, and then you would want to see glucose levels that are over 126 milligrams per deciliter, or 1.26 grams per liter, and this usually should be done twice, at least 48 hours apart. Or diabetes can be diagnosed by doing an oral glucose tolerance test, of course, when you use 75 grams of anhydrous glucose, and the blood glucose levels after 2 hours should be greater than 2.0 grams per liter. Or you can do a direct test, which is actually the glycated hemoglobin test, and if it's greater than 6.5, diabetes can be diagnosed, especially if you're using the gold standard high performance liquid chromatography method. Or maybe you just do a random plasma glucose and the blood glucose levels are above 2.0 grams per liter in a patient who is actually presenting signs and symptoms of diabetes. So this is the way we can diagnose diabetes. And we actually, at the moment, have all of these methods in Cameroon, probably less HbA1c, which is only in some specific centers. So I just wanted to go through these general notions. What type 1 diabetes actually? So type 1 diabetes is actually a very heterogeneous disease, as we know right now. But it's a disease that is mainly caused by an autoimmune destruction of beta cells, islet of Langerhans in the pancreas. And so it is very common in children and adolescents, but we also know that type 1 diabetes can occur at any age. For example, I actually put the picture of the former British Prime Minister, Theresa May, who was diagnosed with diabetes in 2013. And it was thought that she had type 2 diabetes, but it was later confirmed that she actually had type 1 diabetes because it was doctors were really unable to control her blood sugar with oral treatment. So type 1 diabetes can occur even at an older age and not only in children. So we really take note of that. And so when you talk of type 1 diabetes, as I said, it's really a heterogeneous disease that really occurs as really an interaction between environmental factors and genetic susceptibility of individuals. And recently, there have been some papers that have come out to try to describe the pathophysiology of type 1 diabetes stages, moving from stage 1 to stage 2 to stage 3, where you have an overt manifestation of the disease, usually when about 80% of beta cells are destroyed by really, we know that it's actually T cell mediated destruction of the beta cells of the pancreas. Type 2 diabetes, of course, we know it's common in older people. At the time of diagnosis, most people are going to have complications. It can be treated with oral antidiabetic tablets, also with insulin. At first, in terms of the pathophysiology, this notion was prevalent, and most of us were taught this in school, that type 2 diabetes was mainly about insulin resistance in the liver and in the muscles, so peripheral resistance and central resistance, with some form or relative insulin secretion deficiency. But today we know that the pathophysiology is more complex because diverse organs are actually involved. Moving from the gut with the incretin effect to lipolysis with the liberation of free fatty acids that are going to cause lipotoxicity on the pancreas to cause hyperglycemia, to increase glucose reabsorption with peripheral decrease in glucose uptake, to brain dysfunction, to, of course, to the liver, which I mentioned before, with increased activity of the alpha cells of the pancreas to cause glycogenolysis with the liberation of glucose, and of course with decreased insulin secretion as a result of cytotoxicity of the cells. So all of these and really other mechanisms are involved, and you can see that these different mechanisms are now really targets for therapy for type 2 diabetes. So what are the risk factors or the causes of type 2 diabetes? We know that type 2 diabetes, for didactic reasons, I can say it's usually divided into non-modifiable risk factors, which are age. We know that age, as you increase in age, you are prone to have diabetes. You could see that when I showed the cartoon with Europeans, as they increase in age, you see that diabetes tends to appear more. And male gender seems to be a risk factor for diabetes. With regards to ethnicity, it is known that Afro-Caribbeans, Africans, Hispanics are actually prone to type 2 diabetes. If you have a family history of diabetes already, you should be careful. And if you've had a prior history of gestational diabetes, you should also be careful. Women with polycystic ovarian syndrome, and also those who've had intrauterine growth retardation. There are lots of notions around thrifty genotype that are hidden in here, and more we are beginning to see that if people who've had intrauterine growth retardation, who were actually born during large periods of famine, are actually at risk for diabetes when you look at life course studies which have been published. But also there are modifiable risk factors which are actually like sedentary lifestyle, or being overweight, or having obesity, having unhealthy eating habits, or maybe you've got pre-diabetes, you're smoking, excessive alcohol consumption. These factors would actually lead to diabetes, but we know that obesity, and especially central obesity, seems to be one of the greatest determinants for type 2 diabetes. And when it comes to the treatment of diabetes, I think this is from the Israeli National Diabetes Network. Just really need to say that people have tried to stratify treatment with regards to HbA1c levels, and it usually starts with lifestyle intervention plus metformin for most school of courts. Things can change as maybe you move to nice guidelines in the UK, but usually this is what it's recommended, and has you go and then you can escalate treatment to 2 anti-diabetic treatment, to 3, and then to maybe 2 insulin. And this is actually a position statement from the American Diabetes Association and that of Europe, actually showing what you can do in terms of first line, second line, third line, and the different classes of drugs that are available and the different things that should be taken in consideration, and the different side effects, of course, moving from sulfonylureas to glitazones to DPP-4 inhibitors, SGLT2, GL1 agonists, of course, and then insulin. Talking about insulin, it's kind of, this year it's kind of special because this year marks the 100 years of the discovery of insulin. As many of you might know, insulin was discovered by Benton and 100 years ago. And the shocking truth is that up till date, most of our countries in sub-Saharan Africa do not really have good access to insulin 100 years after it was discovered. And so the Lancet actually has been really talking about this issue and calling for like an equitable access to insulin for sub-Saharan Africa. And of course, we know that diabetes is treated to avoid complications, and complications are generally divided between microvascular, which is regards to the eye for retinopathy, kidney for nephropathy, and distal peripheral neuropathies. But of course, macrovascular complications, which will touch the brain, leading to stroke or ischemic heart disease and peripheral limb disease. But of course, when we know that when you look at the physiopathology, there's really no much divide between nowadays microvascular and occur in tandem with each other to lead to these different complications. And as I said, with regards to treatment, one landmark study was the United Kingdom Prospective Diabetes Study, the UKPDS, which actually started several years ago and showed that if you actually reduce HbA1c, you can actually reduce different endpoints related to mortality, but also microvascular complications. And they also showed that with regards to BP control. And in terms of prevention, it is important to know this is actually from WHO. WHO is actually pruning a holistic approach where instead of targeting the prevention of diabetes, we should target the prevention of NCDs, because many NCDs, non-communicable diseases, share the same risk factors, as you can see, whether cardiovascular diseases like stroke and ischemic heart attack, or diabetes or cancers, or chronic pulmonary diseases. You can see that share common risk factors. And so prevention should target all of these diseases as a package. And I'm sure Ferdinand is going to talk to us more about prevention, especially in the communities. So with regards to diabetes in Cameroon, we cannot really talk about diabetes in Cameroon without talking about macrophage. Sorry, I hope it's not. Professor Jean-Claude Bagna, who is a professor of medicine, I think has been very instrumental for diabetes in Cameroon, and not only in Cameroon, in Africa, and not only for Africa, but for the world at large. And under his leadership as the president of the ID of the International Diabetes Federation at the time, 2011 or 2012, if I'm not mistaken, he actually led the coalition that brought forward diabetes and NCD agenda to the United Nations and to the WHO. And really, it really shifted a great deal, the geopolitics of diseases, from infectious diseases to non-communicable diseases, with an increase in funding towards non-communicable diseases. And so he's been very instrumental, and he continues to be very instrumental for most of us who actually learned under him back in the faculty one day, and many others who are everywhere in the world today. And we know that the burden of diabetes, as I said, is increasing, and in Cameroon it's actually it's actually increasing. And it is known that the prevalence is about 6 to 8% today, especially in urban areas. And that in Cameroon, about 80 people have diabetes without knowing. And only 25% of those who actually have diabetes and who receive treatment are well controlled. 25% is actually much. We've seen studies that actually show less. And that in Cameroon, we know, of course, diabetes is highly associated with hypertension, not only in Cameroon, but all over the world. And these are numbers from the Ministry of Health and from the CDC back in 2012, showing that with regards to mortality, NCDs contribute about 32%, but diabetes also as a whole contributes about 2% to total mortality that we are seeing in Cameroon. And as I said, that there's been an exponential increase in the prevalence of diabetes from 1994. This study was published and showed that from 1994 to 2003, there's been an exponential increase in diabetes, with touching both rural men and rural females, as you can see, and urban men and urban females. And we see that for urban female, actually, the the sex-adjusted prevalence for diabetes is quite high. And I'm sure this has gone further even by 2021. This was done in 1994 and 2003. And with some friends, we actually carried out this a meta-analysis for showing that for some of the studies that have already been published in Africa, especially looking at adult population, the prevalence of diabetes stands at about 5.8%. This was carried out back in 2017. And we also looked at the co-incidence of diabetes and hypertension. This was done in a semi-urban population in Cameroon back in 2014, 2014. And we looked at males, I did note, and then females. And we actually saw that with regards to males, those who had like co-incident diabetes and hypertension, it's about generally for men it was about 6.9%, and for female it was about 8.1% in that semi-urban population in the Western region. And as I said, obesity seems to be one of the major drivers of diabetes in the world, but also in Cameroon, because we are seeing actually an increase, of course, of obesity, as Feze and collaborators showed here. But also, as I mentioned, obesity seems to be more prevalent in urban areas than in rural areas. But now there is this concept where we talk of rural urbanization. Of course, some of us, we know our rural setting in Cameroon, but we know that most of the factors that contribute to driving diabetes, we now see them also in rural settings in Cameroon. And so in terms of other risk factors, we can also talk of urbanization. I've mentioned rural urbanization, sedentary lifestyle, people are no longer active, but of course, smoking and unhealthy eating habits. What about complications of diabetes in Cameroon? I think this study was published by Subgui and collaborators back in 2012, where where they looked at complications of diabetes in 6 sub-Saharan African countries. And this is just actually a summary of what they showed. And they actually showed that in patients who were seen in specialized centers in these countries, only 47% had their HbA1c assessed in the past 1 year. And you could see this was the median HbA1c level in the study, and therefore in most of the specialized centers, so 8.2, really far greater than the required less than 6.5%. And that only 21% of patients had actually had their BP checked, and that it was less and well controlled. That's less than 130/80 millimeters of mercury, and that 65% of them were on treatment. With regards to checking for lipids, only 45% of the patients were assessed for lipids, and only 13% of these were being treated. And 18% of the patients that were seen in these specialist centers had background retinopathy. They also said that macrovascular diseases was rare or were rare, and that 48% of patients had neuropathy. So we can actually see that patients with diabetes in our settings, sub-Saharan African settings, and especially Cameroon, actually do have huge burdens especially when it comes to complications. And this was another study that was published by Jingi, who is a cardiologist, internist in Cameroon. He was looking specifically at diabetic retinopathy using fundoscopy, and they assessed and they saw that 43%, which is quite huge, of the diabetic population they assessed actually had diabetic retinopathy, with 63.4% of them having non-proliferative, 36 having an proliferative. And that, of course, from the picture, duration of diabetes influenced a lot the development of diabetic retinopathy. And this is a study which we actually carried out with Dr. Yannick Bilong, who I think now is an associate professor of ophthalmology in Yaoundé, where we used mobile phones, iPhones at the time, with another device called M2 RedCam, which is actually a manual handle where you can actually connect your iPhone and actually examine the eyes even of premature babies, but also of adults. And we did that in Yaoundé among type 2 diabetic patients, and we were able to see that diabetic retinopathy diagnosed using this method was about 16%. I think we did this alongside some other colleagues in some projects that he was leading at the time. And he was also invited and awarded at the Ophthalmology Time to Research Scholar. He was not the final winner, but I think he had, I think, second or third place at this meeting in the US. Just so we were trying to show that you could actually use smartphones to actually diagnose diabetic retinopathy. What about macrovascular complications? Of course, we know that most of our diabetic patients would develop stroke, ischemic heart disease, peripheral limb disease, diabetic foot, and of course that will lead to lower limb amputations and of course infections. Just to mention that infections are actually quite high among our diabetic patients in Cameroon, and Etoile and colleagues showed in this study back in 2020 that among patients that were hospitalized at the Yaoundé Central Hospital, they saw at the end that mortality was about 7.6% in that population. 50% of patients that were hospitalized came in for diabetes foot wounds. But of course, we know that patients would usually get hospitalized for ketoacidosis or maybe hypoglycemia as a result of treatment, not forgetting stroke and heart failure. But I think the focus of this particular research was that many of our diabetic patients are actually coming down with infections from foot wounds. There's this other study that was published by some colleagues, Eric, who is now in the US, back in 2016, trying to explain some sort of seasonality in diabetes. And not only seasonality in terms of new onset of diabetes, but seasonality in terms of the development of complications. And this was done in the Central region and around the October month, where they actually assessed and saw that there was higher rainfall during that month. There was an increase not only in new onset diabetes, but of course diabetes hospitalizations and hospitalizations for diabetes complications during this rainy season period in the Central region. And so during rainy seasons, we should be careful, probably as a result of the predominance of viral infections during that particular period, and the change of climate usually from August, September, and then to October would cause many of our diabetic patients to decompensate. So we should watch out during rainy season to try to keep our patients tightly controlled. And with some other colleagues, we were looking, given that at times diagnosing microvascular complications can be quite a hideous task. Are there surrogate markers that we can use to identify patients who have high cardiovascular risk? So that was really the question in this study. And so we were using procalcitonin as a surrogate marker, and we could show that, well, there was some sort of a moderate correlation between high procalcitonin levels and those who had high cardiovascular risk scores. And for cardiovascular risk evaluation, we had used the advanced formula, which was initially developed by André Pascal, who is Cameroonian based in South Africa. And we actually compared procalcitonin and highly sensitive C-reactive protein, which I know it's highly used and talked about by cardiologists in the US as a marker for cardiovascular diseases, not only for patients with diabetes, but in general. So, but we saw that CRP did not perform well in our setting, but procalcitonin seemed to perform well, but this really has to be followed up. And so in terms of the treatment of diabetes, we know that there are non-pharmacological actions, usually based around lifestyle modification, focus on physical activity and healthy eating habits. You know, these two concepts are really quite easy just to mention like that, you know, as physicians or as healthcare workers, but they are really not easy to practice. Even with regards to the measuring of physical activity levels, these have to be patient focused, because you cannot tell an old person to do certain kinds of activities. And of course, with regards to healthy eating habits, we all know as you move from northern parts of Cameroon to the southern part of Cameroon, people eat, there is actually a gradient with regards to the food that is available, with regards to the season that is available. So we as healthcare workers, we have to be conscious of this and know that people have different things. How do we put all of this together to come out with a program that we can, you know, it better inform our diabetic patients so that they can eat healthy? It's really, really complicated. And these are things that have not been really studied previously in our setting. And with regards to pharmacologic agents, actually, we know, of course, that there are the oral anti-diabetic drugs such as metformin, gabapentin, sitagliptin, and others that are available in Cameroon and are usually being used. Most of our patients are on metformin and really sulfonylureas, usually glutamate or metazide. And of course, we've got insulin, but, you know, regular insulin around, regular insulin, maybe Apapid, which is very common, or NPH insulin, or maybe premix insulin. With regards to the fanciful long-acting insulin or rapid insulin, some of them are available, but they are quite expensive because these patients have to buy them from the pharmacy. But of course, we have our African pharmacopoeia, like, you know, when you speak to patients, many of our patients, you know, take several concoctions. They will tell you about leaf, some will tell you about stevia, moringa, and lots of stuff. People take this. There are lots of studies that have looked at bitter leaf, which is Vernonia amygdalina, and looked at whether extracts do actually work with regards to the reduction of glycemia in these patients. Some have conflicting results. We ourselves who perform studies with moringa and stevia in Yaoundé, and we are actually seeing an increase in insulin secretion from the use of these different kind of agents. What is the treatment algorithm that we use in Cameroon? So there is now actually a treatment algorithm which was developed back in 2017, you know, which is based on what we have locally. This treatment algorithm was really adapted from the American Diabetes Association algorithm. So if you're diagnosed with diabetes, really step one is still lifestyle management with monotherapy. And this monotherapy is usually metformin. It's one of the cheapest anti-diabetic drugs that we have. And then after 3 months, if there is really no specific improvement, then you can escalate treatment and you move from monotherapy to dual therapy or bitherapy, and there you might be required to add maybe sulfonylureas to your metformin already, or you might be required to maybe to add basal insulin, depending on the glycemic level of the patient. And then you can also escalate maybe to 3 oral anti-diabetic drugs, or you can escalate to maybe putting the patient on insulin. And of course, with regards to insulin, there are several things we can talk about. We cannot talk about all of that today on this call. How do you actually initiate proper insulin treatment? It's a discussion for maybe another time. And we do have agents to treat our patients, but as I mentioned before in the intro, that only about 25% of our patients are well controlled, treated all over the country. And there is an issue. This study was done by some friends, and they showed that there is an issue with regards to adherence to anti-diabetic medication in Cameroon. But of course, when you talk about adherence, there are other factors that actually tied to non-adherence to this treatment. And they tried to bring out some of these factors, and they were forgetfulness, lack of finances. We all know that healthcare in Cameroon is really paid out of pocket. There is the number of people who've got any form of insurance, it's quite small. And some people say they were too busy, some got multiple medications, or some thought that they never had diabetes and their symptoms had disappeared, and so they were no longer taking their drugs. But apart from adherence, in Yaoundé back, we looked at do patients actually with how does following a particular treatment protocol. So in this case, we looked at the treatment algorithm which we had in Cameroon, and we tried to stratify patients who were adherent to therapy, whose treatment actually were adherent to that local protocol, and those whose treatment were non-adherent to that protocol and the different drugs that they were taking. And we looked at also the complications or the adverse drug reactions that they had. And we saw that patients whose treatment was non-adherent to the treatment guidelines actually had more complications, as you can see, with regards to hypoglycemia, 25% compared to 11%, weight gain, 8.9 compared to 6%. So they had more adverse drug reactions than patients whose treatment actually respected the local guidelines. So it's important for us to know guidelines, and not only know guidelines, but as physicians or as clinicians, try to make sure that we actually put the right treatment following guidelines, because these guidelines have been shown to work. And we were just trying to show that, yes, in our setting, if we follow these guidelines, it can work, and we can also reduce adverse drug reactions that we see. You could also see from this that some of our patients had drugs like SGLT2 inhibitors, like diffusine, of course, but at this time, drugs like DPP4 inhibitors are already being used, and they have authorization for use in Cameroon, but SGLT2 inhibitors not, but some patients do have, especially patients who buy their drugs from Europe. So, all right, with regards to the organization of diabetes care, I just really want to focus around 3 big programs that are actually going on in Cameroon. The first is the Changing Diabetes in Children program, which actually it's a program that was initiated by Novo Nordisk and lots of other international partners in Southeast Asia, but also in Sub-Saharan Africa back in 2009. It actually took off in 2010 in most of the countries in Sub-Saharan Africa, including Cameroon. And they actually had a framework with 6 components, which was to improve infrastructure and the supply of equipment and the creation of clinics, to provide adequate training to healthcare professionals, to provide free insulin, because insulin is expensive, and to develop diabetes education in these countries, to create database or creation of registries for patients with diabetes, and also to try to share what has been done with, and see how this as a whole can be used for the development of the healthcare system in these developing countries. And so this program took off in 2010 in Cameroon, and these were the local partners. As I mentioned, Novo Nordisk was at the helm of it, but of course the Ministry of Public Health and some technical partners such as HOPID and ISPAD, which was mainly there for education, and Rush for providing glucose meters. 9 clinics has been created so far in all of the regions, but for the East and South regions where patients still come to the Yaoundé clinic. And also there's the program around the Cameroon Diabetes and Hypertension Program, which actually had strategic axis for the strengthening of the Ministry of Public Health Monitoring and administrative capacity at all levels for diabetes, and building capacity, rollout of improved diabetes care, improvement of NCD surveillance, and the implementation of media-based and community-level awareness. This project started in 2017 in Cameroon in 2 main regions, in the Center region and in the Northwest region, at these different health districts. And the project is now closed, and I think many things were developed as part of this project, that an electronic data registration system for patients with diabetes, lots of education materials, and I think the ministry is really working to see how to roll out this project to the rest of the regions. So recently, we've also been looking at also primordial prevention of diabetes. So this is a project that is initiated by Professor Sabwi, really to bring NCD and diabetes education, not only to patients, but to young people, that's to secondary schools, so that people can know about these diseases, that they exist, so that young people can know that they exist and know the ways that they can use to avert these different diseases. Really focus on physical activity and healthy habits. And so as part of this program, we've developed a couple of curricula that we've given over to the Ministry of Secondary Education, and they are working in tandem with their partners to see how to implement this or include this into the different programs for secondary schools in Cameroon. And there's also this app which you can get free of charge in Google Play Store, which actually would help you know the different Cameroonian dishes we have, and know their different composition, and know what you can do to make them lighter, to make them less fatty, and how you can really just eat healthy. So this app is available free of charge on the internet. And so before I end, maybe in the next 5 minutes, I just want to talk about the last session, which is the case study I mentioned on how to set up a hospital-based diabetes care center. So this is actually my story. I left medical school back in 2011, and I was posted to work, like many of you who are on this call, at the Bafoussam Regional Hospital. So when I got there in 2011, I actually started work in 2012. At the time, I was back in 2011, after med school, I was actually doing an elective in South Africa at the time, at Chris Hani Baragwanath Hospital at the emergency center. Very busy, learn how to do basic life support, was learning advanced cardiovascular support and all of this stuff. Got back, and then, was just thrown into the emergency department at the Bafoussam Regional Hospital in January. And I started working really 8 a.m. to 9 p.m. at night, a young guy working. All those old doctors just really abandoned me and left. So one thing I noticed was that there were many people who were coming with diabetes emergencies at the emergency department. Lots of stroke, lots of people coming with diabetic ketoacidosis or hyperosmolar oncotic states. And I witnessed all of that. The mortality of diabetes at the time was quite high. And really for a young man, I said, really, I think we should really organize. So I met my director at the time, who said, Professor Afeti, I said, really, I think we can organize diabetes care at the regional hospital. So how can you do it? I said, I can write something and then you're going to see. So he said, okay, why not do something? So I actually wrote a project around the World Diabetes Day celebrations around the 14th of November 2012. And he looked at it and he said, well, he was going to support it. So we went out into the communities, to educate the population about diabetes. At the time, it was really all community-based, screened over 1,200 adults, brought those who had increased glucose levels and increased BPs, invited them to the hospital for follow-up and for checkup and counseling. And really, that's how it started, with this kind of a small place. And I used to consult just behind this. We had just this small, one room kind of thing we had back at the time, November 2012. So we started organizing, especially organizing around type 1 diabetes care and doing just really counseling. And then from there, we progressed. And when the hospital administration saw that we were actually, growing in terms and doing some kind of a good job, they decided to give us another area in the hospital which was larger, and they gave us a team, and we actually formed a team back in March 2013 with I actually had started with Madame Fokapo, who was the nurse at the time. It was young and handsome at the time, and started medical consultation. And then the regional delegate got involved. He said, but I have a dietitian at the regional delegation. I'm going to send her to work with you guys. And that's how Madame actually joined. And then later on, Madame Tange joined and Mr. Akbar joined. And then we really started the whole thing, just really like a joke and from scratch. The hospital management gave us 7 hospital beds and a small room for diabetic food, management. And we started with children with diabetes, and then later moved to adults, installed paperback data collection system. We still continued some form of community outreach. At the time, I was really focused training nurses how to do HbA1c. At the time, we had this point of care instrument from Biorad all into it. So we were using to do HbA1c for our patients, training them how to use electric syringes, which I had gone back to Yaoundé to collect, and this really drastically reduced mortality from diabetic emergencies at the hospital. Trained all the nurses. The nurses were confident and they could implement, a sliding scale protocol with the electric syringe and rapid insulin at the time. There's this one particular case. We had a young 13 months old toddler. I remember we diagnosed her with diabetes. She had come in, she was diagnosed at the emergency having severe malaria. I remember one Saturday I was not on call and I just came back. I used to live near the hospital. I never had a wife at the time, so the hospital was my wife. So I was basically spending all my days at the hospital. I remember getting into the emergency and I saw this young child. I asked, what does she have? They said she's got severe malaria. But you could really see the Kussmaul breathing. It was so clear, but nobody thought about diabetes. And I said, have you guys checked her blood sugar? And they said, no, we checked her blood sugar. It was over 6 grams per liter. And checked her urine. She had ketones. We started sliding scale at the time. And I think she was in a coma for 2 days, but she got out of it the next day. And lo and behold, it's true, she had diabetes. Eventually, she got off insulin for a few years. Some of us, we know about the honeymoon period, but later on, she's on insulin and she's still very much alive. This was back in 2015. We went further to really starting organizing camps for children with diabetes, the Changing Diabetes in Children program. We had this young guy who actually was known to have developed blindness in the village for over 5 years. And when he was diagnosed with diabetes, we actually saw that he actually had cataract at the time. And so his cataract was operated thanks to the Changing Diabetes funds at the time. And here's the guy seen, and he went on living his life, normally taking care of his diabetes. He could now see, he could do his injections, he could read and other things. So really at the time, I was working with Dr. Demken, most of you know, Dr. Romans. We were all working at the time, the emergency department, back at the Fusam Regional Hospital, and that year, 2012, 2018. From lots of our activities around diabetes, I was awarded the Governor's Award for outstanding service to the hospital that year. And since I could not, carry on winning the same award, I had to just really slow down for Francis to take the award the next year, in 2014. And so by the time I left in 2015, so we had left a thriving diabetes unit with over 70 children registered with type 1 diabetes, over 200 adults with medical records, the diabetes food clinic, and there was now like diet and nutrition counseling program going on at the hospital. So I'm still in touch with most of the team back in Bafusam. They just recently organized their Diabetes Day celebration. And so later went forward and really have been into training since 2016, whether with regards to residency training back at the University of Yaoundé in public health, and now PhD in medical science in diabetes. So I'll end by saying that I usually love what I call my crossroad model, which is really in life, if you want to grow, you should have people who are ahead of you. You should have people who are by you, which you cross-fertilize ideas. And you should have people who are under you, which you are able to pull as well as you go up the ladder. So this is not really hierarchical, as I said, but it's just my conceptual model of growth in life. And really, Professor Jean-Claude Bagna and Sir Eugene, they've been very instrumental for me. And most of my other colleagues with whom I work with in Yaoundé, Dr. Loni, whom I share most of my ideas and projects, Dr. Majelang, who is a biochemist, Dr. Mapa, who is also in public health. Thierry is an engineer who really brings most of our ideas to life with regards to apps and stuff like that, and other engineering pipelines. Dr. Donald, who is now in the US with most of you guys and the others on my team, and some of the other people who are actually being sponsored on my PhD studentship for my research, with whom we are doing some work around diabetes in Cameroon at the time. So I'll end by saying really thank you, and probably I could not touch everything around diabetes in Cameroon, but we can talk more when we go to the Q&A. Thank you very much.
Wow, thank you, Dr. Kati. This was deep and this was exhaustive. Like, you touched on all the key points, and the chat has been busy. So please, if you have any comments, just feel free to drop them in the chat, or any questions. But we plan to take all the questions at the end after Ferdinand's presentation. But for now, while we are giving Dr. Kati a few minutes to breathe and giving Ferdinand a few minutes to prepare his slides, we're quickly going to say hello to a few new people in the town hall and gauge the temperature. Dr. Kati, wants to see if you've set people on fire, or if you've, calms down their anxieties. So we're going to check on the temperature in the town hall. I see Anne Bully is here with us. Hi, Anne. Anne Bully? Okay, maybe she dropped off. We're just going to call on the next person. Darlene Augustine. Yes. Hi, Darlene. Hi. Good to have you at the town hall. Welcome.
Thank you. I didn't hear your question because I'm at
no problem. We're excited to see that, despite you being at work, you're able to make time to join us. Where are you joining us from?
New York City.
Oh, nice. How are you finding the presentation so far?
The sessions are great. I was actually at the clinic with the I definitely would like to attend a few more to see that first. I think I sent you an invitation.
Sorry, could you speak just a little closer to your mic? I think we are struggling a bit to hear you.
I think it's true. An invitation I think
Okay. Well,
it's
thank you so much. I know we completely understand that you're in the middle of work, and we appreciate you joining us, and we appreciate your service to our people. Thank you so much for joining, and just stay tuned because we have a lot more coming. Yes, you wanted to say something.
chat.
Sorry. Okay. Thank you so much. You could also just drop us a message in the chat so we can just follow up with you, but we see that you're caught up in the middle of work. And lastly, we're going to call on Dr. Ringo. Dr. Ringo, are you here with us?
Hi, Alison. I am here.
Always a pleasure having you around, Doc. How are you finding Kate's presentation? Did he set you on fire? Is he touching on key things, or would you want him to elaborate on a few more things?
Oh, definitely a great presentation. I think Dr. Kate has done a very great job on this subject matter, giving us from the global perspectives to our country perspectives. He has painted a picture that, to me, I find very representative of our context. And he ended up with actually demonstrating what commitment does to a medical doctor. And I am very proud that he took up the challenge. Most often we always complain that the system have not done this for us or done that or made this possible or made that possible. He took the bull by the horns and made sure that he imposed his vision to a locality where maybe diabetes was still a mystery to people. And bringing out things into limelight like that is very good. I would be interested to find out a lot more about how this care center started so well. How has it been faring so far? And what are the barriers? Equally, he has raised a lot of issues around early onset diabetes amongst young people. I think for a disease that was often considered for the old, young people should become more and more aware. And I have seen the programs that have been launched to make young people to be aware that diabetes is not so far away from them as we always think. And therefore, we should be discussing more around what is done for these people. We equally saw from one of his graphs that women in the middle 20s, in the early 30s, are having a lot of diabetes. That is a very big concern. And so we should be discussing with him if that particular observation, those statistics have called for action and what actions have been taken around women. Is there something that the gynecologists are doing to make sure that they target women to prevent diabetes in them? So a lot of things. I think that during our discussion session, we'll be coming back to some of these aspects so that we can further clarify the issues around diabetes. But great presentation, Dr. Kate. You are doing well. Thank you.
Thank you, Dr. Ringo. So Dr. Kate, Dr. Ringo has already started, sharing some of the reflections that are coming out from your presentation. So while Mr. Sonyo will be going on with his presentation, you could start reflecting around what answers you'll be providing to Dr. Ringo's questions and many other questions, reflections, and comments that we might have from our participants and our viewers on social media. I'm now going to hand the floor to Dr. Sonyo, to Mr. Sonyo. Ferdinand, are you ready to take it away? Can you share your screen?
Okay, they say host disable participant screen sharing, so maybe you need to give me some rights.
Okay, just give us a few minutes. Sorry for the technical challenges. We'll just check on that in just a minute.
Yeah, he's able to share now, I think so.
Awesome.
Great.
Yeah, we can see your screen.
Can you see the screen?
Yes, we can.
Okay. Okay, so I just wish to start by thanking the town hall for inviting me. Thank you so much, Dr. Kate, for inviting me to be part of the session today. I count it really a very huge privilege and an honor for me to be with you today. Thank you too for making me to see my sister, Alison, who is doing a great job also here at the town hall. So I think that I listened to the not just the first presentation, but even the opening words from the leadership, and I was really touched by the vision. And I really just want to throw my weight behind the vision and to say that this is really a most powerful vision. And I hope that it's going to really contribute to the growth of care in Cameroon. I'll be speaking mostly from a public health perspective, health promotion perspective, from advocacy, which has been my, I would say, the focus of my work within the past 7 years. And you will probably hear some cytokines and nucleic acids and many other strange details in clinical science. But I'd like to draw us to some of the concepts that relate to community engagement, the role of community engagement in access to care. And you know, when we talk about community engagement, the first question that comes to mind should be really, what community are we engaging? And maybe why are we engaging those communities? What kinds of communities do we need to engage? Of course, we have to engage communities in order to improve access to care, but the question really is also, how are we going to do that? How can we successfully do that? So my presentation will essentially be looking at a few communities that we need to engage and proposing strategies around that community engagement that could possibly inform our work, so that as we proceed with improving access to care, we can actually leverage some very important concepts of community engagement to achieve some very impactful success. So I hope that the few things I will share will be very helpful, useful to the town hall. So normally when we talk about community engagement, we're talking about a process through which we collaborate with groups and people who are affiliated by either geographic proximities or some special interest or similar situations, such as people living with diabetes, you know, affected by a particular issue, and then we're collaborating with those people in order to address issues that are affecting them. And one key thing here is that community engagement is a very powerful tool to actually bring about change, because there is this key statement some of you might have heard about nothing for us without us. I would like to give the example of a community of HIV. And I'm bringing this example because we're talking about diabetes. We have World AIDS Day coming up, and we have the example of the fact that I think Dr. Kate mentioned this, that we're celebrating or commemorating 100 years of insulin discovery, but yet we have not really had that insulin practically available for use in many African countries. That story is very similar to what happened with HIV as well, where there was medication for HIV, but it had to take decades for Africa to have access to HIV medication as well. But you had this medication available in higher income countries, but people were still dying in Africa. So how did community engagement help to transform the challenges that were present with respect to HIV and AIDS? Community engagement in HIV and AIDS is a perfect example of how important community engagement can be used to improve access to care, even for diabetes and other non-communicable diseases. As far as HIV is concerned, it was actually called Greater Involvement of People Living with HIV. And the idea behind it was really about the fact that people living with HIV need to be recognized in terms of their rights to access care, but also the fact that they have the right to participation and the right to self-determination and to participation in all decisions that were about their lives as far as the care is concerned. And of course, we all know the story because today, medication for HIV is really, I would say, almost free. And so many support services that they have that are subsidized, and there is a lot of attention that is given to that. But the question is, how about chronic NCDs, including diabetes? There is still so many needs and concerns and for people living with chronic conditions that are almost very difficult to, it's very difficult to comprehend why they are not being met. These needs are not being met. So there is need for us to look at involvement of people living with these chronic conditions and what is happening around taking care of their needs. So one of the key things that I've been involved in around community engagement is the Global Charter for Meaningful Involvement of People Living with NCDs, which was recently launched in September 2021 by the Global NCLA Alliance. I happen to work with it also with the development process of it from my role in the Cameroon NCLA Alliance as well as the African Entities Network. So there was a very structured and very broad consultation for over 8 months to come up with this particular charter. And so the Charter for Meaningful Involvement of People Living with NCDs is looking really at the fact that the value of people's lived experience, the community of people living with NCDs is important. There is a lot of value in the lived experience when it comes to engaging in the NCD response in general. And so the charter is actually a tool that you would like to look at, which supports meaningful involvement by institutions that are interested in working on engaging the diabetes community. And the key things in the charter are the fact that it provides a shared understanding of what meaningful involvement is to all actors. We know, of course, that it can mean different things to different people. And so the charter provides a shared understanding of that. But the charter also provides some core principles as well as strategies that I'd like to share some of those with you that can be applied by different sectors to achieve meaningful involvement. And I'd like to also indicate the importance of the other communities that are engaged when we work on meaningful involvement of people living with NCDs. And that includes the people living with NCDs themselves, because when we talk about community engagement, they are the first community you think about. Then you also have governments. You have private sector, not all private sector, but the relevant private sector, then civil society, academia, and then you have other institutions. All of these are different communities that when we engage, we will be able to, I would say, really do a lot of, would really accelerate our desire for impact at the level of improving access. So why do we go through meaningful involvement as our strategy for community engagement? Now, when you talk about community engagement, when it comes to access to diabetes care, the first community I would like to encourage is that we look at the people living with diabetes themselves. But then if you look at the people living with diabetes, you can't ignore other communities. And those communities are the list of communities I've indicated. You have governments, of course, different sectors in government and the other sectors. But when you look at this engagement through the lens of meaningful involvement of people living with NCDs, it becomes more interesting because cover grounds with what is most important, which is the people. You put the people at the center, front and center. The people we're caring for front and center in community engagement. So the charter gives us 5 principles and 10 core strategies for achieving a people-centered NCD response. And in terms of those principles, they are simple. We're looking at it from a rights-based perspective. It is the right of people with these conditions to participate in their care. They have the right to live their full potential despite the challenge or the condition that they have, and they cannot be discriminated against in any way, shape, or form. And we have to be as duty bearers, we have to be aware of of the obligations to respect and to protect and to uphold their rights. They also are entitled to respect and dignity. We have to have the human part of our engagement has to be people-centered, very humane in our programs and our services as we design them. We need to put ahead the needs, the priorities, the concerns of people living with NCDs as we engage. And we need to ensure that we don't leave, I would say, anyone behind in terms of different kinds of groups, particularly rural communities, people with disabilities. We need to look at equity as well. And then we need to ensure that there is outright participation by putting in place formal mechanisms to ensure that people living with NCDs they also have the power or feel that they have the power to inform and influence the kinds of decisions that are made around them. And I'll still like to go back quickly to the fact that if you look at the decisions that are being made about insulin, I would think that so many of those decisions are not being made with the challenges, the needs of people living with diabetes who need that particular medication in mind, and it's manifested in the lack thereof, as we can see. Now, going to the strategies, I'd like to indicate here that there are 10 core strategies, but going to each sector, whether it's academics, whether it's government, whether it's private sector, civil society organizations, there are different strategies that can be developed from, that have been developed for each of these sectors. But these 10 strategies I want to share with you now are the core strategies that we invite all institutions to look into. They cut across the principle of meaningful involvement. And so the first thing we call on is to have institutions demonstrate their consciousness and leadership and commitment to meaningful involvement. That means to show that they value the lived experience. One of the most loved people in my life is my elder brother, and he says experience does not lie. You cannot cheat experience, and so this is the same thing that we're talking about here. Experience cannot lie, and so valuing the experience brings in a very unique perspective, a very forceful, unique perspective to driving access. And the second thing we need to look at as far as our strategies for meaningful involvement is concerned is that we need to formalize opportunities for meaningful involvement in decision-making processes, be it in programs and services and policies. Currently, in the Cameroon NCD Alliance and the African NCDs Network, we don't just create committees and teams. We always, for example, ensure that there is someone with a lived experience in committees and teams when we are designing programs or services or projects or whatever intervention or initiative we want to carry out. We also have to ensure that meaningful involvement is contextually appropriate and that it just respects the culture, the context where we want to practice it. And then we have to also ensure that we have supporting environments that really promote that meaningful involvement. Sometimes it can be challenging, but we need to just make sure that we break the barriers that try to stop us from adequately involving people living with diabetes and other entities in our initiatives. So one of the key things with meaningful involvement is that we need to always define upfront, because not just what we mean by meaningful involvement, but how we are going to effectively involve people living with NCDs in our activities. Because like I said, many people might think it differently. There is something we call tokenism, which sometimes it can look like you're using the people, but there has to be a shift from that to determining what do we really mean by meaningful involvement and how can that be achieved. And then we need to develop some transparent processes in doing that. And at the same time, we need to make sure that we provide training to people living with diabetes for their own meaningful involvement, and then provide support as much as possible for their involvement. And then, of course, we need to also ensure that we use language that is appropriate to meaningful involvement, as well as support different organizations and communities. So what are the action points from here? I'll be inviting the town hall to endorse the global charter as well. It's still open for endorsement. And then I'll also be inviting the town hall to look at the strategies and what aspect of it that you can employ to take action. And then, of course, we are here. One of our plans is to make sure that we track the progress for meaningful involvement in Cameroon. We will be working with the Global NCD Alliance to track how meaningful involvement is being practiced at different levels in Cameroon, but also in the continent. So this is the link.
It looks like we lost Ferdinand.
I think so, Alison.
Okay. So I think maybe what we're going to do is we're just going to take it away from here, just to see if he's going to come back. I suspect maybe his internet is not very stable where he is currently. All right. So if Ferdinand joins us at any point, I think, he can always just hop in and we continue from there. While waiting for Ferdy to come back, Mr. Chairman, Ferdy has recommended that the town hall should endorse the global charter. What do you think?
Yeah, I think they're doing a wonderful job, and truly that's what the town hall is meant for us to be able to advocate for patients back home to be able to have access to what I would call essential medications, essential care. And that's just what the Global Charter is doing. And I personally am going to endorse them. And I would encourage everyone else to do the same. And as I said, each time there are different parts of the body which are meant for different things. Our goal is to encourage other organizations that are already doing great things. We cannot start from afresh. That's one of the things I want Africans to always know. We can always work this journey together. So organizations that are already existing, it's a platform for us to actually get to endorse Ferdinand and the charter and what is going on. And I would fully encourage everyone to do the same. So Alison, you have my 100% approval, but the rest of the town hall needs to decide, but I think they should just go ahead and do it.
Thank you, Mr. Chairman. All right, town hall members, when I don't hear, Oga Chairman don't endorse the Global Charter on meaningful involvement of people living in entities. So, Freddie, I see you're back. Can you hear us?
Yes, I'm back.
Okay, awesome. Please take it away. Or alternatively, we could share your slides from this side. I know Kathy has got your slides. I don't know if it's going to work better for you that way.
I think I'm almost done.
Okay,
and
awesome.
I think this can pull through from this point.
Okay,
yeah.
gotcha.
So, So in terms of the way forward for community engagement, I would just like to say that when it comes to access to care, can absolutely be supported by meaningful involvement, by aiming for meaningful involvement, by institutions aiming for meaningful involvement. Access to care can very seriously and very strategically be supported. And to date, this is one of the things that has been lacking in terms of innovation or in terms of providing a certain kind of inspiration for innovation towards ensuring or accelerating access to care, especially when you look at the fact that policymakers needed to act. There's so much that policymakers need to act on. There is so much that, of course, different organizations need to act on. And so this aspect of meaningful involvement is something to really look into for mainstreaming by institutions. And the other key thing is that meaningful involvement is everyone's business. It should be everyone's business. It's not something that should be relegated to the doctor and the patient. It should not be relegated to the public health people and the patient, or to civil society organizations to talk about or to shout about or to just promote. It should be everybody's business. Even a parliamentarian, whatever sector, it should be everybody's business. And the other thing I'll add is that we need to actually reach a point. We need to understand meaningful involvement to the point where we agree that we have to hold ourselves to account on whether we are really practicing the principle of meaningful involvement. Not just doing it maybe because this is a strategy, but because it's an essential way of functioning, to drive that change. So sometimes when I think of meaningful involvement, it looks like I should have an NCD before talking about these things. But one of the key lessons I've learned in life is that you don't need to wait until something touches you personally before you do something about it, especially if it is right. It is right to ensure that we adequately and appropriately involve people who are actually going through the challenge of chronic conditions in their care. And so, to conclude, I'll just say it's now we have to leverage this concept of meaningful involvement if we have to be strategic. And I'll just end by acknowledging some of these organizations with whom I've worked and that have been participating in the process of meaningful involvement. Thank you so much.
Thank you, Fedi. And we are sorry to see that, you had initially some technological challenges, and we appreciate you, taking it through despite these challenges. So for everyone who are keen on learning more about the Global Charter, we've put the link in the chat. So check it out. And as you guys have heard, the chairman of the town hall has endorsed it. So please look at it and think about it. He also recommended that we endorse the Global Charter. Fedi, thank you so much for these great insights. We are now getting ready to open the floor for questions, comments, reactions, suggestions, proposals for partnership, and maybe funding. We might have some funders here on the platform with us. We have no idea who's joining us. So we are very, very keen on listening to all of you. We had some initial comments and questions in the chat, Kate, these pertain to your initial presentation. And for those of you who have other thoughts and comments, please feel free to drop them in the chat or indicate by show of hand on Zoom, and we're going to call you to, mention or to ask your question. So, Dr. Kate, we had a question around the implications of diabetes in pregnancy. I don't know if you have some thoughts around that.
Thank you so much, Madam Moderator. So diabetes in pregnancy, it's quite a complex issue, quite complex, because the first step to the complexity is actually making a diagnosis of diabetes in pregnancy. And in this case, and so there are two scenarios. You've got gestational diabetes, which is like first onset diabetes during pregnancy, or a lady who's got diabetes already, maybe type 1 or type 2, who then becomes pregnant. That's something else. So how do you diagnose diabetes in pregnancy? In this case, gestational diabetes. There are lots of how can I say? There are lots of international consensus on the matter, but obviously the gold standard is that you should do an oral glucose tolerance test. That means you need to bring the lady into the hospital between after the 24th week, right? That's after the 24th week. And then you have to give that lady glucose and then take the fasting sample first, give her glucose, and then do the 2-hour glucose. That's already very time consuming, 2 hours. Then you need to draw bloods and so lots of stuff. So in Africa, we are pushing more towards doing a unique approach, doing like a fasting glucose. And we know that in our situation, we mostly do capillary glucose and not plasma glucose. So you see the complexities that are already getting into the whole diagnostic issue of diabetes. So, but it's getting more and more common. And if a late, usually, it can be managed through dietary measures, but dietary measures are not always okay. Treatment has to be maybe escalated with now we know that oral anti-diabetic drugs can be used during gestational diabetes, but mostly insulin. And so it can be, and that is treated. Now, what really further complex is the whole issue of diabetes is that pregnancy outcomes are affected for the mother and for the baby. Adverse pregnancy outcomes usually happen. And so, I don't know, gynecologists would really want to take the baby before full term. Some would wait, but there's the risk of increased growth. So it's very complex in our setting, but it's been treated. And for the woman and for the person who is involved and the baby, there are lots of issues with regards to heredity, with regards to now developing full-blown diabetes after that period of gestational diabetes. So it's really a complex issue. We really need to talk more and study about it and really see how to diagnose and prevent. We know that African women, we usually gain weight a lot during pregnancy. That alone complexes the matter, leads to glucose intolerance. How do we effectively devise strategies and interventions that will reduce weight gain during pregnancy? So those are some of the challenges, but that I can mention.
Thank you, Dr. Keta. Mr. Sonyoy, a quick question for you. After working in the communities around, getting them to understand diabetes and manage their diabetes better, what has been, or what have been some of the highlights of your experience? Maybe you could, mention some of the strengths or the good experiences you've had and some of the challenges that you've had working in some of our communities back home.
Yeah, I think the very first challenge when it comes to diabetes care in Cameroon that I've seen is really the challenge of cost. Every World Diabetes Day, this always comes up. One mother, one father will have to raise their hand up and make this particular point that their drugs should be subsidized, their medication should be subsidized. This is always one of the key points for years and years and years. So there is need, and I compare this with HIV medication again, and so that we can see that in the field this is a very important need. And then secondly, there is always a very serious bias within the healthcare system in terms of attention that is given to disease care and conditions. Like Dr. Kate mentioned, the national health system really has not taken that much of a critical view to consider chronic conditions, of course, including diabetes, in a way that care can translate into some, well thought out, well laid out, and followed through processes. Even promises that commitments that are made in that regard are hardly kept. We had a situation a few months back where I really admired the patient. That was the head of the leader of patients who take their kidney dialysis care in the regional hospital. They stood up to the fact that they cannot have to travel to Bafoussam to have their dialysis. And something was done about that. That's the power of the patient voice. But that should show how the system too needs support or strengthening to be able to handle. So the health workforce is also another angle where sometimes you do not have that particular focus to the point where staff are dedicated. So you always have part-time staff that are working when it comes to diabetes. So you have people who actually work in other areas, and then when it comes to the diabetes clinic, they move to the diabetes clinic and function there and then come back and things like that. So there is no system, there is no incentive for innovation. For, when you focus on something, you can begin to bring innovations there. So when you have staff who constantly are within that functioning space, they can begin to think about how to improve even the access to care. They can begin to think about how they should follow up patients even at home, home-based follow-up, which, for example, you see would have been very critical during COVID-19, but never happened in many cases. And other innovations. So we need to be able to make sure that the health workforce for care of chronic patients is actually there. And again, I will draw a lesson from HIV before I end this. There's something called the chronicity of HIV, and one important fact is that the way HIV is being taken care of, it was learned from how chronic conditions were being taken care of, how diabetes, hypertension, that is a long-term condition, was being taken care of. But right now, those systems that are functioning well when it comes to taking care of HIV, they are no longer functioning well when it comes to NCD. So aspects of integration, aspects of really looking at some of these things are critical. So, but there has been a lot of improvement, serious improvement. It's not all dark. as you saw in Dr. Kate's presentation, I've been able to interact with the Changing Diabetes in Children program. I've also interacted with the National Diabetes and Hypertension Program. I think there's an evolution in it that is going towards doing a bigger program that includes kidney disease and other cardiovascular conditions. But also I've participated in strengthening about 12 diabetes clinics, and there's also the other medicines access initiatives, even though the last one I knew about, the Novartis Access Initiative, has been a failure. It has not worked, and so there are some works around the corner to try to mend it. But those are some of the challenges that we're seeing in the field.
Oh, thank you, Ferdinand. This is really insightful. And you touch on core things like funding, which does come up a lot in our setting. And I'm glad Dr. Wingo is here. He initially had some thoughts for Dr. Kati after his presentation, and I'm glad he's here. Dr. Wingo, this is going to be a question, that's probably going to involve a few reflections, both from yourself and Dr. Kati. And I'm curious, there's this theme that keeps coming up about a lot of funding going to infectious diseases like HIV and malaria, and less for NCDs, like in the case of diabetes. As someone who is involved in policy, I don't know if you have some thoughts around this, like how can we get to draw more attention to some of the, NCDs like diabetes in our settings, and how can we get more funding being driven to these conditions? I know that funders' influence can be very powerful. A lot of times where we put our work and our time can be highly influenced by where the funders want to put their money. But as someone who is at the level of policy, how can we get some of these diseases which are ravaging our populations to get more attention and more funding for our researchers and the people working in these areas?
So maybe I'll go first, then Wingo will go second. So it's a very difficult question. I mean, there's a whole Lancet commission, I think back in 2017, looking at diabetes in sub-Saharan Africa. And they actually came out with 5 main panels, and one panel dealt with the issue of funding and diabetes care and research in sub-Saharan Africa. Infectious diseases, they are still going to be funded a lot for Africa, I don't know, for the next 20, 50 years. The truth is, if you look at the global tendency, infectious diseases, there seem to be a decline. And malaria is an example. Though we know that children are still dying of malaria, thank God we have the vaccine today. But there seems to be a decline. And while there is a decline, there is an increase in NCDs. But in Africa, we are in the middle of these two. So we have like a double burden of both infectious diseases and non-communicable diseases. And so our policymakers usually find themselves in the fix, where do we allocate funds? But most of the funding that comes for infectious diseases, for example. And just little funding goes to non-communicable disease. I think just the non-communicable diseases department at the ministry, I think, was created just only back in 2004, and really up till date, it hasn't really gone up. They are not up and running since 2004. And each time you go to the ministry and ask, they will tell you there is no money, there's no funding. How can you solve this? You can solve this by generating local activity. How can we find local ways of generating funds to carry out activities now that can be seen and that would generate interest? How do you get right people who can compete for that small pot, allocated pot of money that exists in international organizations for NCD? If at the ministry level, for example, at the country level, we don't have people who can effectively, go into that competition, with rigorous scientific methods or with rigorous and strong projects and bring that money to the country is not going to come. And funding from the government for NCD, it's very low. It's very low. Most of the times we depend, having spent some time at the Department of Health for the Department of Disease Control. Most of the activities that go on there or they depend on foreign funding. And at times when there is no foreign money, when there's no CDC, when there's no World Bank, when there's no WHO, then people sit down and say, on a pas les moyens. So we still have that tendency in the government where we want to wait for people to come and we are not trying to do things. So I think when we start getting things done, then we make noise about it and then we are going to attract people. So that's, for me, that's.
Oh, sorry, Katin. Thank you, Dr. Kati. Dr. Ringo. I'm not sure if Dr. Ringo is still here with us. Maybe while we wait for Dr. Ringo to join. Okay, awesome.
Yes, Alison, I can pour a small perspective on the funding question.
Yes,
so I've actually worked in fundraising as a grant writer for 2 years, and then in working in other capacities, that particular skill or perspective has supported my work very greatly. And one key thing I find to ensure that we have funding is that you cannot be funded for an inexistent solution. We sometimes can really have the problems. We can really have the issues that are happening. We can really appreciate the challenges from clinical care to community-based care to research. Whatsoever aspect is challenging, that is where that's the first step. The first step is whether there is someone who is able to see, there's someone who is also willing to commit in terms of action. Now, one way our government works in Cameroon is that, like Dr. Kata has said, the government still has this issue of not investing themselves, not going into their coffers and taking and investing into issues like NCDs right now. So there is this waiting spirit to have funding, and especially from civil society organizations that work very hard to bring in funding from foreign donors. So that is something. So in terms, we need to push at the level of government to encourage the government to learn to do more budget allocations for themselves, for their own NCD work. But we need civil society to keep on doing what they're doing, to design, like the Cameroon Town Hall is, like I said, this is a very great forum. You have the power and the ability from both your numbers and your capacity to design and implement the solutions. There are very many funders out there who have shortage. Their tables have shortage of people who have proven that they know what they are doing, who have the solutions in their hands in terms of plans, in terms of those proposals. So I'm currently working with a group in Oxford who are focused on research and collaboration with Africa, between Africa and Oxford for research on NCDs. Now, this is new, but that came about because we made the case and said, look, you cannot have a one-time in 2 years training session in Oxford, and you have 15 people from across the world come there, and you think this is going to really help anybody. So we said, bring that course to Africa, and we're ready to organize it in Africa, and then you collaborate with us. And right now the collaboration is moving towards providing funding for researchers as well. So for those who might be interested, they can be more discussion on that. But practically what I'm saying is, let us be people of the solutions, and then we will see the funding flow in. But we should guard against the fact that we need to put our government in a position where they take primary responsibility by their own funding, and then they support civil society organization when we work very hard to also bring funding to support their work on NCDs. Thank you.
Well, thank you, Fedi. That was, on point. I see the chairman nodding. Okay, chairman, Ferdinand has thrown the ball back to the town hall, and I see your hand is up. Do you have some suggestions, some comments?
Yeah, Alison, thank you very much. And Ferdinand said a lot of things I wanted to say. First, including we need to invest in health, meaning the government, and we need advocacy from the civil society for the government itself to invest in health, especially in things that we are not able to get funding. The government in Cameroon still is investing less than 5% of our gross national income. We need to be at 15% if we're going to make changes. We need to also understand that when you're dealing with diseases, every funder wants to prove that they're doing something. So they're giving you money and they want to measure outcomes. Outcomes are easy to measure in infectious diseases, quite complex to measure in chronic diseases that are going over a long period of time. So we need to get innovative in how to measure these outcomes and get measurable outcomes that can actually influence funders, because no one should be giving you $100 million and you're not telling him what you're doing with it. He feels you're maybe scamming him. So we need to also come up with innovative ideas on how we're going to measure these outcomes. If we're giving it for diabetes and everyone is still dying, or everyone is still getting microvascular complications and macrovascular complications, then it becomes very difficult how to measure these outcomes. I think that's one of the reasons that a lot of people, they actually chicken away to want to sponsor infectious diseases more, because they're going to get vaccines that are going to end the pandemic. They're going to get solutions that would really cause a drastic change, and everyone is going to see their impact. Everyone wants to have a big name. A lot of these organizations also want to have a big name, apart from helping people. Health system strengthening is a very important part, and integrating, having a situation where we can integrate all our non-communicable diseases in a particular platform which is already working can be a big solution to what is going on. Like, okay, Kate created, his example was very, how do I call it? I felt really, this is a young man who brought change. Okay, I could call him a young man because he was my friend and my junior, and I could always see change in him. So this was someone who went to Bafoussam and caused change. This change could be replicated all over Cameroon. And this could be a model for us to emulate over Cameroon and see how to get these things done. And these are things that the government could actually deal on that, invest on that. And there are issues with community engagement. I've always found community medicine, community engagement, one of those things that you can actually foster change in any society. If not of the community, today HIV medications would still have been that expensive. It took the national HIV, there was a conference in Zimbabwe when they lined up corpses. If you have ever heard about it, you can go back and read it. In the late 90s, they lined up corpses on the street for the international organizations in Harare who came for the meeting to see it and understand what it means for medications to be available in Europe and in America, where in Africa, no one could get zidovudine, stavudine, and lamivudine. It took everyone to see that community engagement, getting those who are sick to get to participate, getting those who have family members, getting the leaders in the community can always drive governments to make a stand. And HIV has taught us a lot of lessons about that. Another thing is sustainability, which we have it's a big problem we have back home. Yes, we're getting money, we're asking for money. Now, these funders also do have their objectives, which they want to have a goal. How are we going to sustain these projects when they leave? And we don't usually factor that into each project that we're trying to get funding for. So it's something that we should think about. Mine was just a reflection. I had other questions, but I think other people's hands are up. I didn't really have a question to ask. This was just a contribution. And I see other hands that are up, and a lot of them have wonderful ideas to share. Thank you.
Thank you, Mr. Chairman. I noticed Dr. Ringo is back. Dr. Ringo.
Yes, Alison. Yeah, sorry about the brief disconnection. Exactly at the point when I was about to take the floor. And I appreciate really the intervention from our two presenters and say that it is not always an easy job at the level of policy. You know, policy is very inclusive, but at the same time, there's a lot of prioritization that is done at the level of policy. When we look at infectious diseases, we come to realize that in the years before the year 2000, nobody really paid much attention to these communicable diseases, infectious diseases. And despite the fact that data was not collected, it is very easy and understandable to say that the slow development of African countries was largely due to the fact that these infectious diseases affected the productive population and prevented them from being productive in the socioeconomic domains. When we look at all the infectious diseases, they are mostly transmissible. What target groups do they affect? The target group of every country that is supposed to be the ones that are responsible for development. So at the level of policy, the policymakers ask themselves very basic questions. Who does this disease affect? And how does that influence our socioeconomic development? And when they look at this particular question, they find that, okay, if a disease is going to kill more of my children that are less than 5 years, what is the future of the country? Obviously threatened. So they think that it is better to prevent these diseases because they affect a population that is responsible for posterity. So they base more of their resources on that. It doesn't remove anything from the importance that it is to support diabetes. When we look at our health sector strategy in Cameroon, you see that NCDs, they occupy a position of choice. But however, when the donors who come to our countries, and because we depend very much on external funding, it is very difficult for us to set the agenda and to drive the movement. Because the external people are coming from a perspective that if these diseases are transmissible, if these diseases can cause a lot of chaos, if the lethality rates are too high, we better, from a global perspective, control these diseases where they are so that they don't get to us. So in dictating their agenda, they definitely invest more in what is going to constitute more of a problem for them. When we look at NCDs in the developed world, we realize that they are very innovative. They are they are advanced more than us. When they talk about kidney problems, they are now talking about kidney transplanting. We are still in dialysis. So is it too much of a problem to them? No. Is it too much of a problem to us? Yes. But how much are we investing in it? Very small. So our problem, just like our chairman was saying, is that we have not invested enough in health to prioritize NCDs the way they should be prioritized. So I'm very happy Ferdinand is bringing up the debate, but saying that from a global perspective, priorities are totally not the same as we see in our communities, in our countries. Now, he raised the issues around meaningful engagement. I think it's quite an interesting concept that I'm still to read about, because we have a lot of community engagement going on. Now, when they bring the notion meaningful, I must tell him that I really didn't grasp what that concept is all about. Because when it comes to community engagement, we are trying to make the community understand that part of the solution, a greater part of the solution to this problem, lies in their hands, and they can do something about it. So we are now trying to empower them to do that thing that we are saying they can do to make sure that the solution to that problem is actually sustainable, because community engagement is all about sustainability. So if we are saying today that communicable diseases, especially diabetes, needs some special kind of funding, I would be very skeptical, because I would not like us to think that the solution to diabetes today is funds. The solution to diabetes today is effective communication. Effective communication, because a lot of myths always follow chronic diseases. When somebody has HIV, for a long time, people will say that is Musong, they threw this thing to him from the village and all the rest. So effective communication is something that we should focus on before we start talking about asking for more funding. Because the question I'm going to ask here is, what do we want to do with the funds that we are looking for? What do we want to do with them? It looks like a very strange question, but I think we should have the guts to ask ourselves that question first before asking for more funds. It's just a very open debate that I am trying to put on the table now, because it's going to help us to know that we can do much more than we think we have been doing, and with very little demands in terms of funds and resources. Let me stop there for now so that the others can give in their own thoughts. Thank you.
Thank you, Dr. Ringo. Thank you for adding kerosene to the fire that's already burning. Dr. Agbo's hand has been up. Dr. Agbo, please take it away.
Okay, thank you, Alison. Thank you, everyone. Thank you, Dr. Kate and Ferdinand, for the two outstanding presentations. I very much enjoyed the presentations, and Dr. Kate in particular, especially. There are two main slides that I like, and I would like to comment a little bit on them. One of them was the one that you had the modifiable and non-modifiable risk factors, and the other one where you mentioned the epidemiology. So in the epidemiology, I think currently, based on a study you guys carried out a few years ago, it's approximately 5.6% in Cameroon. So I think 5.6% for diabetes is high in the first place, but I also think that's an underestimation. But most importantly, I think from the population, the different age groups that were affected in Africa and particularly in Cameroon, it was mostly the young people, I think around 40 and 50 years, between 40 and 50 years. So this is the working population. So when we are talking about outcomes, like the chair mentioned something about outcome, and a few other people also mentioned something about outcome. So the age group that is affected by diabetes in particular is the working population. Those are the people who work. If they are not feeling well, they are severely sick, they can't actually work. And what that means is that the outcome is productivity is going to be very, very low. So the reason I'm going to talking about this is that for all the presentation with everything we've discussed, one of the things that we missed, or maybe I missed, was we really didn't talk about prevention. So in most countries, it might be the same situation in Cameroon, but I'm not aware. So if I make a mistake there, please correct me. I know there are screening guidelines for some of these diseases. In diabetes, for example, usually the recommendation is that people greater than 40 years, men, women, 40 years plus should be screened at least once every 2 years or something like that, without any risk factors. And then with risk factors that could happen earlier. So the point I'm trying to make is one of the most effective measures for this kind of disease, especially a disease that has a treatment, has a diagnostic test, is through screening. If you screen and identify these people, and especially this now will take me to your other slide where you had those the risk factors, where you have the non-modifiable one, like those of us who are getting old, we really can't change the fact that we'll get old. But then you have those other ones where you control your diet, exercise like 3 times a week. And there is another point that you mentioned about our women, and actually even our men, our women getting bigger around the abdomen, but even our men are also getting pregnant these days. So those are some of the things, like I think the chair also mentioned something about strategy. So those are some of the things I think we should focus on, because as much as you can do in the hospital treating the patients, you understand that the doctor to patient ratio is very low. Some of you who are experts in the disease are very few. This is going to overwhelm you. But if we prevent people from getting these diseases, especially non-communicable diseases, like I think a few weeks ago we had a one on stroke and generally lipid cardiovascular disorders and diabetes. These are diseases that can be prevented. And one way to effectively prevent this kind of disease is like through screening. You screen the population, you prevent the disease before it's developing. In the case of diabetes, in one part of your figure, when you mentioned the diagnostic test and the cutoff, there is a part which was there which you didn't mention, which you didn't talk about, but I think it's because of time constraint, about the pre-diabetes or the impaired fasting glucose. So when you test an individual and they present with an impaired fasting glucose, that is something that can be reversed through modification of lifestyle, exercise, diet. So I think we probably need to do a general shift from focusing on treatment to focusing on preventive medicine. I know there is someone here who calls me primary, someone primary prevention. So I am a big advocate of primary prevention. So I think instead of, I'm not saying treatment and cure is not important, but I think for this kind of a disease, which can be prevented, and the way the trend is happening in Africa and Cameroon in particular, with a lot of pregnant men, I think we probably need to do a fundamental mental shift. That was just my comment. And if also there are clinical practice guidelines recommending screening at 40 years or for people with risk factors. And then I had a question for you. It's a very small question about you showed like a couple of those kids and I think a young adult who was being treated. Was that type 1 or type 2 diabetes? And were you able to identify the specific cause for those patients?
Okay. Thanks, Dr. Agbo, for your intervention. Those were, quite tough questions. Let's just all catch a breath. And maybe before we take Sustani's question, Dr. Kate and Mr. Sonyo, I don't know if you would want to address Dr. Agbo's comments.
Well, I mean, his comments are on point. He mentioned prevention, which is key. And of course, what is recommended is that generally now, if you are above 30, you should at least do a blood sugar test every year. If you can, a plasma blood sugar test. Because, as you rightly said, we are seeing very young people with diabetes. And now we are seeing young people with type 2 diabetes at the age of 20s and 30s, no longer 40s and 50s. Why? Because there is a global increase of obesity all over the world. I'm sure we are aware of that. And as obesity is increasing, whether android obesity or which, it's usually the one that is, or that confers the highest risk for metabolic disorders. It's increasing all over the world. So we are seeing young people. Also, that life expectancy generally in sub-Saharan Africa is low. Many people don't live above 60 years. So you would see that the age foreshot for people to have these NCDs is still around the 40s, 30s, and 40s now in our population. Now, there are many other theories. I mean, I cannot go deep into theories like small pancreas theories, like intrauterine growth retardation, which I mentioned because of years of famine, because of years of food scarcity in some parts of sub-Saharan Africa. Those things are driving, and there are actually studies to prove that these theories can be verified in our society. What do? We should focus on prevention. Now, I did mention that there are some primordial prevention strategies that are already ongoing to teach school children about these diseases and things and how they can do to prevent. Why? Because we know as ourselves as adults, it's difficult to modify lifestyle. You've lived over 30 years, you've got your lifestyle, you've got your eating habits. I'm not saying it's impossible. I said it's difficult. You really have to be motivated. And we now know that even with diabetes, with lifestyle modification, you can completely reverse diabetes. That is true. And so it's true, we talk a lot about prevention. It's quite difficult in our setting. It's the cheapest. And, with education is the key. But we need to develop and streamline all of this. Remember, I talked about how do we deliver, when we say physical activity, when we say eat healthy, how do we as healthcare practitioners deliver that conveniently? We don't yet have packages in Cameroon. We don't have a structured education system that targets specific. We just say, oh, mommy, you should eat vegetable. How are you sure that mommy has vegetables even? Remember, I talked about food grade in Cameroon. We need to learn about all these things and now develop programs. And we have people at the moment who are focusing on doing what we call medical education, or sorry, diabetes education diagnosis with patients so that the patients contribute. So we've got a student working on that so that once we do the diagnosis for our patients, we can now with our patients develop programs together that will help them. So those are some of the things we are doing. Intervention, of course, it's quite difficult, but these things are ongoing. That's just all I wanted to say. Your question around, so we have children who've got type 1 diabetes. We've got other children who've got type 2 diabetes. It's quite difficult to make the actual diagnosis in our setting. We just rely on our clinical knowledge and maybe test on treatment because we don't have access to antibodies readily. We don't have access maybe to C-peptide to make sure diagnosis or even genetic analysis, but it's changing. And those are some of the things that I'm actually leveraging in my PhD project. And maybe in some future, I'm going to present you guys the exciting results that we are seeing from Cameroon.
Thank you, Dr. Kati. Ferdinand, I don't know if you have some extra comments. Maybe we just make it quick for the interest of time so that we take Dr. Sostani's question. It's maybe going to be the last and then give Brian the floor to, round up. But Ferdinand, I don't know if you have some last comments or additional comments to what Kati has said already.
Yeah, I just want to quickly align with one or two key things that I think in a session like this one, we should really even have like take-home messages and build our future work on. And the first one is on what Dr. Wingo said, which is about communication. And I want to add that it's communication and advocacy. The place of those two is critical. In civil society, we say our work is based around 4 A's. We have awareness, advocacy, access, and accountability. These already tell you that based on the stage in which we are in Cameroon, all of that is very critical. And so I agree very strongly with Dr. Wingo that communication is a very serious gap. And I'll add that with advocacy, there is a lot we can do. Because if you look at the challenges around access, if you look at the challenges around understanding the problems, if you look at even the challenges around what we need to say to draw more attention, to make sure that even the government allocates necessary funding, takes responsibility, different sectors take responsibility, it really truly revolves around communication. And so I'll add that communication and advocacy, but also hard work. And then I'll also agree with Dr. Agbo that, of course, prevention, because if we have prevention, we won't have need for a lot of care. Thank you.
Thank you, Ferdinand. Sostani Enuru, please take it away.
Thank you, Alison. Sorry, I'm outside with my children walking around. But I'm very impressed with this conversation today. I've known the presenters have been fantastic. I've known Kate for such a long time. Come back. I've known Kate for such a long time, and I'm really impressed at this work which she's doing. We spent a lot of time doing diabetes in Cameroon, in Bakusam before I left. So this is impressive to see how much she's done. One thing I want to say is I'll join Agbo to say that you need a lot of prevention is a very good thing and important thing in this diabetes care. I think before I left, I did one study with Mbanya on self-care in diabetes. It involved putting some funding and it involved motivating patients to come out to be involved in physical activity. The sad thing is that we had to pay these patients to come out for physical activity. We have to pay their transportation. It was like simulating the benefits of physical exercise in their diabetes control. Results were fantastic. The results were excellent. But why do you have to pay someone to get out to do physical exercise for something which is beneficial for their health? So it's sad. Our population needs the people themselves they are empowered. They know what is good, but for some reason, physical exercise is such a very difficult thing for everybody. To be self-motivated to go out and walk. About funding, I think we need to be on the table where decisions are made to be able to allocate funding for the problems we think are a priority. A lot of attention got paid to diabetes over the years because of Prof. Jean-Claude Mbanye. I think he was the pioneer who pushed this agenda over a while. All of us worked with him, and maybe that's why I understood diabetes a little bit better after I spent that time with him. And I think it was because he was on the table where he could advocate and push for funding for diabetes for Cameroon. I'm sure that's why we get it. So I'm glad we have Kate, who is following this path, and many other young people. As you grow up, please sit on decision tables. Push funding. In Africa, it will be difficult to suppress infectious diseases. Because that's what, no, that's not. No, it's not your money, don't take it. So it will be difficult to surpass infectious diseases based on our current infectious profile in Cameroon. So as our own people growing up, Kate and other advocates, please sit on decision-making tables. Advocate for non-communicable diseases, not only diabetes, all other non-communicable diseases are suffering in Cameroon. Advocate for funding for those. Government doesn't see it as a priority, unfortunately, but international communities, local communities do not put much money in health. It's not a priority for our system. So I encourage self-care, I encourage prevention. The cost of diabetes, I still go back to Jean-Claude Mbanye. I pay so much respect to this guy because we saw the cost of diabetes cut down because of his advocacy. Generic medications for diabetes started coming to Cameroon when he started on IDA. And that's why we got it to this. Yet even at the generic cost, it's still expensive for a majority of people, right? So local funding, local resources, international resources is all of what will help us to solve this problem. Thank you. That's my.
Thank you, Dr. Inoru. And courage with juggling the town hall with daddy duties. All right, so we are just going to round up now, and we're going to do a recap of the main talking points for today, just so that maybe those who came in late can have a sense of everything that we've covered. And for those of our viewers following us on our different social media platforms, they can have a sense of where we are. So we had two presenters today, Dr. Jean-Claude Kate and Mr. Ferdinand B. Sonyoy. And, the main topic for today was diabetes care in Cameroon. So Dr. Kate began by painting, first of all, by defining diabetes, which in terms of definition, diabetes is known as a group of metabolic diseases that are essentially characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. He next went on to paint a picture of the situation of diabetes globally and even zoomed in to tell us what's happening in Cameroon. So for the key highlights from this section, 4 in 5 adults with diabetes live in low and middle income countries, so Cameroon included. And diabetes touches every age group. We used to think at first it was for older people. Now there is data that it touches every age group, and that diabetes disproportionately affects young people in Africa. You will see the highest number of deaths in this age group. It is twice in the urban than rural areas, and it tends to show a pattern of seasonality, especially in the context of Cameroon, where we see that a lot of our patients who are diabetic tend to decompensate during the rainy seasons. With regards to its exact burden in Cameroon, it's not quite clear yet. It seems to be quite underdocumented. However, there is evidence that the prevalence could be somewhere around 5.8%. Looking at the types, we have essentially type 1, which tends to be more of an autoimmune disorder, where we have destruction of the cells that will produce insulin. And it's common in children and adolescents, but should not be excluded or can still be found in older populations. Type 2 tends to be more lifestyle related. And that's where some of our public health measures could have the hugest or the biggest impacts as we are thinking of where to invest our funds and our time. Next, he looked at diagnosing diabetes and he highlighted 4 main ways. So it can be either done through fasting plasma glucose, oral glucose tolerance test, glycated hemoglobin checks, and random plasma glucose testing. So each of these different tests will be available at different levels of our healthcare system. And as healthcare providers or patients seeking care, we should keep that in mind. Looking at treatment, there are several different treatment modalities available. You could either be done through anti-diabetic treatments or African pharmacopoeia. However, he did emphasize that lifestyle modification, which comprises essentially of physical activity and healthy eating habits, is definitely going to be the way forward for us, considering all the challenges that we have in our system. And treatment in people who already have diabetes, the aim here is to avoid complications. And these complications could either be micro or macrovascular complications. So we should ensure that our patients do not develop these complications because they can be debilitating. And instead of, really just targeting on preventing diabetes, we should have a bigger view of preventing non-communicable diseases as a whole, because other non-communicable diseases share similar risk factors as diabetes. Now, Ferdinand highlighted that we need to think about, approaching diabetes with community engagement at the back of our mind. And with community engagement involves working collaboratively with groups of people affiliated by different factors in order to bring change in the lives of these people. And 5 fundamental principles underpin successful non-communicable disease response when you're looking at community engagement. And these principles include rights-based, so whatever engagement or activities we are doing at the communities need to respect the rights of the people. The engagement needs to ensure that we are being respectful of the people and that we are conserving their dignity. The interventions need to be people-centered, equity needs to be respected, and social participation needs to be ensured. We've gone further to look at some of the organization activities around diabetes mellitus happening in Cameroon. And just to highlight a few, we have Changing Diabetes in Cameroon, which is primarily being spearheaded by Novo Nordisk. We have the Cameroon National Diabetes and Hypertension Program being championed by the Ministry of Health. And we have the Guide d'éducation nutritionnelle à l'attention des élèves des établissements secondaires au Cameroon, which is an initiative which is aiming to teach students, even at secondary level, about how to eat better and prevent diabetes before it even happens. So these are some of the interventions aimed at raising awareness. And Ferdinand also highlighted that he's involved with the Global Charter, which is a very powerful group that's championing for the benefits of diabetes prevention and proper management in our communities. So at this point, I'm going to call on my co-moderators to give some final comments and remarks as we prepare to round up today's edition of the Town Hall. So Brian Sigomo, do you have any last comments?
Well, thanks, Alison. I thought it was a really interesting discussion today on really diabetes care, and I think I will take this to the parking lot, but really about ways in which this initiative that Dr. Kate started on diabetes care in the different regions and some of the challenges that they are facing and how this can really be expanded to other African to other countries as well. Well, other regions, because not all regions were listed, and just some of the challenges that they are facing, and what are some ways that, you know, stakeholders can really help and be involved, can really help, and how can this be really be expanded. I think this was really, really very educative session, and I learned so much, Alison. It's really intrigued. I think one of the things that struck me the most was when Kate showed that global diabetes map. And what I noticed, which was kind of striking to me, was how there was such an overlap between the countries where we were seeing the highest diabetes rates is kind of overlaps with the same countries where we are seeing the highest deaths to, you know, COVID-19. So that huge overlap. So I think what this is really telling us is, you know, addressing non-communicable diseases, diabetes, cardiovascular diseases is really in some ways really addressing some of the fundamental challenges that we've been faced with the COVID-19 pandemic as well. I think that's a discussion for another day, but I think this was a really insightful session, and I really want to thank Ferdinand as well for his comment, and I really want to say thank you for your work for the global chat. I think it's really important initiative, and I mean you have my endorsement, of course, and I really want to applaud you for everything that you're doing, and really great work, and much grease to your elbows. Thank you so much, Alison. Over to you.
Thank you, Brian. Christelle, vous êtes là?
Yes, thank you, Alison. Thank you very much. Merci beaucoup, merci infiniment, Dr. Kate. Merci infiniment, Monsieur Ferdinand, pour cette belle présentation et pour tout ce que vous faites pour le pays, pour les patients qui souffrent de diabète. Merci infiniment. C'était un honneur de vous avoir et au plaisir de vous revoir. Merci infiniment encore. Alison?
Merci beaucoup, Christelle. Louisa, are you still with us?
Thank you, Alison. Thank you so much, Dr. Kate, and thank you so much, Ferdinand, for the wonderful presentation and for all that you are doing with regards to diabetes care in Cameroon. I also wanted to add to what has already been said, that prevention is still key, as you said, and in as much as there are challenges regarding prevention of non-communicable diseases, we should not give up. We should keep looking for means to help in curbing the increasing prevalence of non-communicable diseases in Cameroon. Also just want to apologize for those who had technical difficulties during the presentation. We hope you still got something out of the presentation. Thank you so much, and hope to see you in the next town hall. Alison, over to you.
Thank you, Louisa. And we're going to hand over to the chairman of the town hall to give the final vote of thanks and to close our 38th session of the Cameroon Town Hall for Healthcare Providers.
Wow. I just always say, I don't know exactly where all these talents come from. And truly, they say the amount of talent in Cameroon could really change Cameroon from a third world country to one of the most classic countries if the leaders could listen to you guys talk. So we know that, Ferdinand, thank you very much for your advocacy. Thank you for doing what you're doing, and do not stop. Just keep doing it and believing in your community. We believe in you, and you're going to change minds as you progress, and you're going to change the world one day at a time. And maybe at the end of this all, we will say that we reduce diabetes in Cameroon and other non-communicable diseases. So thank you. And we are very honored to have you here with us. I would want to thank Dr. Kate, who is a regular here with us. And we keep thanking him every time. And I remember right from Kate's interest in diabetes, and he chose where he could make a difference. Meaning that we could all decide. It's always a pride thing for us physicians to realize that what we do in the hospital doesn't really change mortality. I always have this to say, after 100 years, the WHO was looking into what has changed human increased life expectancy. Everything that was cited never included a doctor, never included even nurses could actually be included in this whole thing. And the core things was the discovery of antibiotics. 2 was the discovery of vaccines. 3 was public health measures for sanitation, which was number 1, hygiene and sanitation. The 4th one was stopping smoking and the campaign against smoking. And the 5th one was all health interventions that we do in the hospital, combined in all fields. So this tells you that you chose the right thing, public health, and that's where you make a difference. As Dr. Abo said, prevention is better than cure. Louisa said the same. And I want to thank the moderators, and I just want to say wow to Alison and the others. They do it every week. I am super proud of the ownership everyone has towards this town hall. And please, this town hall, as I said, they keep telling chairman, and I don't really like that name, but this town hall belongs to you all. You all take ownership of it. Continue it. If there is a day I don't want to get into here, it should continue, please. And I know there are times people have come into the town hall and asked questions. Why are we not getting into doing things? It's because we have others in this association who are, or in these organizations who are already doing things, and we are ready to support them. You cannot do everything at once. If your goal is education, we can do certain small project, but if you have a big project that you want us to go by this project, bring it over to the town hall. We will try to support it as a little, but we are going to go for advocacy in changing Cameroon by educating Cameroon. So there are other projects that have been born out of the town hall. I'm just trying to say this, and I'm going to start with some other health workers. I'm trying to start a podcast or series where it's going to be for where I'm specialized in, I specialize in oncology. Back home in Cameroon, I did clinical pathology, and I'm also a public health specialist, but my advocacy would be, I'm doing this with Dr. Kathy, Alison, and others, but I'm going to start a podcast where my advocacy is going to be training healthcare workers on one cancer a month, trying to enlighten them on how to, healthcare workers in particular, and the layperson, one cancer a month, and this is going to be under the mentorship of the town hall. So we'll have like a teaching or just a session that we'll go through with that. So Alison, thank you very much. I want to thank all the moderators. I want to thank Christelle in particular, always for helping us bridge the gap, the language gap we have in our town hall. I know it looks more Anglophone, but we are incorporating the whole Cameroon, and we want to go forward with this idea. So thank you very much, and God bless you all.